Okay. Okay, sure.
Not so many, please. Okay. Yes.
All right.
So Derek, do you want to go ahead?
Yes, thank you. All right, so welcome everyone and thank you for coming. It's my pleasure to introduce Dr. Moyses Szklo as a presenter of this inaugural Translational Epidemiology seminar series in the department. So this seminar series is part of the Translational Epi initiative in the department that was led by David Dowdy along with other faculty in the department. Dr. Heather McKay and I are organizing this seminar series, and our aim is to continue the excellent work that he and the group started a few years ago. So Dr. Szklo, our presenter today, was one of the first to define translational epidemiology, and he called it, quote, an effective transfer of new knowledge from epidemiologic studies into the planning of population-wide and individual-level disease control programs and policies. And we are delighted that we have an opportunity to hear more of his thoughts on translational epi. Dr. Szklo is a pillar of the department with countless contributions not only in the methods and practice of epidemiology, but also cardiovascular disease epidemiology. He was the principal investigator of the atherosclerosis risk in community study and the MESA study. He is a university distinguished service professor and was the editor-in-chief of the American Journal of Epidemiology from 1988 to 2019, and he has the distinction of being the editor-in-chief emeritus of the journal. So we are pleased that he's able to deliver this inaugural lecture of the Translational Epi series, and we thank him very much for presenting.
Okay, thank you, Derek. So, you know, I felt like saying whoever still remember Epi 1 doesn't have to be attending, because a lot of the stuff I'm going to do is so straightforward, but it kind of stuff that people forget about, and I think it's important to remind you. So let's see. You know, starting Morton Levin. You know, Morton Levin was an important epidemiologist. I mean, he actually was the first one to report on the association between lung cancer and smoking. And he also developed the population attributable risk. But look at what he says, very interesting. When I got the Frost Award from the American Public Health Association for my contributions to epidemiology, I was surprised, as I always saw myself as a public health officer. And then he said, oops, I'm sorry, I have yeah. He said, my main contribution as New York health officer was not the lung cancer study. It was to have facilitated the polio trials and to demand that they use random allocation. And so, was he an epidemiologist or a health officer? I'll leave it up to you to answer that question. I think both. That's the right answer. I'm having a problem with my computer. It's freezing. Huh. So, you know, epidemiology, when you talk about the interface between epidemiology and health policies and programs, epidemiology is present in all phases of this public health loop. And I just want to show you, it starts with the burden of illness and distribution in the population. Then it goes to, I'm sorry, but I'm having this problem, etiology, burden of risk factors, efficacy of intervention, effectiveness, cost effectiveness, implementation of policy program, monitoring of policy program, and then reassessment of burden of illness and risk factors. And epidemiology is present in all those phases except implementation and the cost side of cost effectiveness. And the realm of translational epidemiology, so translational epidemiology is more related to steps 5 and 6. So how do you define translational epidemiology? So Derek has used the definition that I came up with, because I didn't see any paper defining translational epidemiology, but in general, the definitions, they really heavily focus on clinical applications. And this is, the definition that I propose: effective transfer of new knowledge resulting from epidemiological studies, including trials, into the planning of population-wide and individual-level disease controls, programs, and policies. And in fact, if you look at the classical definition of epidemiology, the translation component is there. The study of distribution and determinants of health-related states or events in specified population, in the application of this study to control health problems. So there is a need for translation of knowledge into application. So what is the process of knowledge translation? Okay, this is actually the ideal process. Now we start with the literature, of course. Oops. We start with the literature, and ideally, we go to systematic reviews, or sometimes single studies. Sometimes, a single study is enough. For example, the toxic shock syndrome, the case control study had such an incredibly high odds ratio, almost 11, that, action was taken on the basis of that single case control study. And then afterwards, we have the evaluation of levels of evidence, programmatic options. This is decision analysis, with or without sensitivity analysis. And then we go to cost effectiveness and recommendations. In the recommendations, there's always a tension between evidence and obstacles. And that tension has to do with ethical issues, politics, and resources. So we start the process of knowledge translation looking at the levels of evidence, right, based on the literature. And what I'm going to tell you is based on the United States Preventive Services Task Force and the Canada's Periodic Health Examination Task Force. So this is a simplified process, system. They start with the highest level, which is at least one well-designed randomized trial has shown the intervention does more good than harm. In the second are the observational studies, cohort or case control studies. The third are the natural experiments with dramatic results. In uncontrolled experiments suggest that intervention does more good than harm. And there are lots of examples, streptomycin and TB, insulin and diabetes, and so on. And finally, the lowest level of the weakest is expert opinion that is not based on evidence. Okay, so we have from experimental to observation, natural experiments, and expert opinion. Now, certain very important areas can only be studied using observational design. For example, the impact of taxes, cigarette taxing on initiation or cessation of smoking, and many social epidemiology studies. So don't forget, observational epidemiology is terribly important. How is knowledge translation done? Now we have this sentence here that I love, this phrase that William Farr once remarked, that is a fact, all else is inference. So talk about inference, you need committees for translation and implementation. And those two agencies, the US task force and the Canadian task force, they came up with the following system, the following classification. So grade A would be there is high certainty that the net benefit is substantial. B, there is high certainty that the net benefit is moderate or moderate to substantial, in which case you design and offer, provide the intervention, the program, or implement policy. Then grade C is there is moderate or high certainty that the net benefit is small, in which case you offer the program or the intervention only if other considerations support offering or provide the intervention on a case-by-case basis. So in other words, we're in the realm of case finding rather than population-based strategy. And then there's a moderate high certainty that there is no benefit or that the harms outweigh the benefits, in which case we should discourage the use of this intervention program. And finally, the current evidence is lacking or poor quality or conflicting, in which case, if you offer the intervention, individuals should understand the uncertainty about the balance of benefits and harms. Now, let me show you an example. A few years ago, I was asked by the Brazilian Minister of Health, before this stupid president we have now, sorry about that, so whether or not they should implement population-based screening for prostate cancer. And, looking at the levels of evidence, I found out that there was at least one well-designed randomized control trial, and showing that the effectiveness was there. I mean, it varied, of course. It went from 4 all the way to 42% effectiveness in clinical trials. Those are all randomized trials of good quality. Now, what about the second component of the level, which is that the intervention does more good than harm? All right, so one problem with PSA, the screening for prostate cancer is done with prostate-specific antigen. It is a certain cutoff point above which the test is regarded as positive. Now, lots of false positives and lots of causes of false positivity, both transient and long-term. The long-term benign prostatic hyperplasia is an important cause of false positivity. Now, if the PSA is positive, biopsy follows, and that has some side effects, some complications, severe pain, hematuria, hematospermia, fever, meaning infection. Now, biopsy can be positive or negative. If it is positive, then the cancer can be potentially invasive or never invasive. And until recently, any cancer detected by biopsy was subjected to surgery or radiation therapy. Now, the thing is that prostate cancer is not invasive in a high proportion of patients. So, the recent meta-analysis shows that in whites, almost 1/3 of prostate cancers found in autopsies are indolent. They're not invasive. In blacks, even more, almost half. So that if you do surgery or radiation therapy, there will be some important complications, mainly urinary incontinence and sexual impotence. So, okay, so the other point here that I think is terribly important, yes, the effectiveness in reducing prostate cancer mortality ratio is there. However, when you look at all-cause mortality, it's almost the same in those people who are randomized to the screening or the control groups. So on the basis of all those data, what happens is that there's a new strategy for men with very low risk of disease. The urologists now recommend active surveillance rather than immediate treatment with surgery or radiation therapy. And Johns Hopkins has actually an interesting classification system of very low and low risk profile for prostate cancer. And I'm not going to go over this, but just for you to know that at this point in time, very low and low risk prostate cancer is not immediately subjected to therapy, to radiation therapy or surgery. All right, so let's move on. Well, on the basis of all those data, and you can see it's not a straight line, right? You have pros and cons. The US Preventive Services Task Force, just as an example, they say for men aged 55 to 69, before deciding whether to be screened, men should have an opportunity to discuss the potential benefits and harms of screening with their clinician. And they give it a C recommendation, meaning case finding instead of population-wide, because they say the level of uncertainty is moderate or high, but the expected net benefit because of all those things that I mentioned to is small. Now, for men who are older, 70 or older, they do not recommend screening for prostate cancer. Okay, now let me show you something that I think you may have heard before, but I think is important for translational epidemiology, is the choice of strategies. We have basically two strategies in public health. One is population-based, population-wide, and the other one is high-risk strategies. And I think an excellent example is really hypertension. So what is the high-risk strategy? It means that you identify, treat, and control all patients with hypertension. So in other words, this is a big challenge, right? To identify, to treat, and to control all patients with hypertension is almost impossible. But if you could do that, it's estimated that stroke incidence will go down by 15%. Now, the problem is that a high proportion of cases of stroke, they come from pre-hypertensive levels, not from hypertension only, but also pre-hypertension. So what the population-wide strategy would do is to actually shift the whole curve to the left. For example, if you have an average decrease in per capita salt intake by about 33%, the decrease in stroke incidence will be higher, will be 22% instead of 15%. So, high-risk strategy is less efficient and less effective than population-based, population-wide strategy. All right, this is one of my favorite topics. In some papers, in some textbooks, they have a classification of bias as bias due to confounding and bias due to not to confounding. So the question is confounding always a bias? Okay, confounding is a phenomenon of observational epidemiological studies. Now, observational studies, of course, are in good company. Have a lot of observational sciences, geology, astrophysics, ecology, and so on. But of course, in observational studies, residual confounding is an important threat to causal inference, which is sine qua non for primary prevention. However, many epidemiological studies on which policies are based were observational in nature. Lots and lots. Okay. However, is a confounding association useful for public health? Now, what is the common reaction among epidemiologists and students of epidemiology about confounding? Confounding must be prevented, exterminated, destroyed, eradicated, right? And if you look at the natural history of a study, then it's quite clear that confounding is not a bias. Let me show you. Let's look at the natural study. You start with a hypothesis, then you choose your study base, select your study participants, collect data, look at the results, interpret the results, and publish. And for each phase, there's a bias, a potential bias, plausibility bias, selection bias, informational bias, analytical bias, inferential bias, and publication bias. So where is confounding? Well, confounding is in the population itself. It's only a bias for causal inference purposes. So how does that work? Okay, I'm using a case control study to show the difference between bias and confounding. So in bias, let's say you have cases and controls and the odds of exposure is exactly the same. So there's no association. But when you select controls, in this example, it could be cases, but in this example of controls, there could be bias sampling. And in this example, the odds of exposure is less in this sample, the study sample, than in the total study base. Now, reserpine and breast cancer is a great example. This study was published, and it created a lot of noise, interviews and newspapers and headlines and so on, showing the reserpine, which is used for an old medication used for blood pressure control. The odds ratio was 2.5. But those two authors decided to reanalyze the data, and they didn't show an association. So what happened is that in the original study, controls with cardiovascular disease were excluded. Well, reserpine is associated with cardiovascular disease. So the odds of exposure went down, and as a result, the odds ratio was biased and, severely biased. 2.5 is a relatively strong association. Now, what about confounding? Confounding, the study sample merely replicates what you show in the study base. So there's an unbiased sampling of cases and controls. And there's some examples, depression and heavy smoking, African Americans and hypertension. For example, smoking initiation has a relationship with suicide, suicidal ideation, and it's a confounded association because the confound is depression that also, both causes smoke initiation, and of course is related to suicide and suicidal ideation. So what is the use? Well, smoke initiation defines a high risk group for depression and suicidal ideation attempt. So that's one example. The next example is even more clear, in my opinion. African American ethnicity and hypertension totally confounded by poverty and everything that goes with poverty, excessive salt consumption, obesity, and so on. But is it useful? Yeah, it is useful that African American are more likely to have and develop hypertension. So African American ethnicity is a high risk marker. So it's useful for screening of this high risk group for control of established hypertension, and focus on this high risk group to promote prevention or cessation of those modifiable risk factor. So another example, if you're a health officer in charge of allocating resources for the care of patients with Alzheimer's disease, we adjust for age when comparing two population groups. Now, of course, the answer is no, right? We're not studying causation, we're studying risk groups. All right, so I said in some modern epidemiology and biostatistics textbook, you have this classification. But in old textbooks, I found Lilienfeld's textbook from 1975. He mentions three types of association: causal, indirect, which is the statistical or confounded, and artifactual, which is based. And he says in the book that causal and indirect are true. They're not a bias. So what is the bottom line? Is confounding a bias? It depends. Yes, if the purpose is to infer a causal relationship. No, if the purpose is to identify risk markers. And Donna Spiegelman, when I was lecturing on this, she created those names, those expressions. This one is etiological confounding, and this one is public health confounding. Okay. All right, this is another topic that I really like discussing, the primacy of the additive model. Epidemiologists and students of epidemiology are totally addicted to ratios, right? I remember when I was the editor-in-chief for HAE not so long ago, 99% of the papers that I got mentioned odds ratios, relative risks, rate ratios, hazard ratios, and so on. But look at this. This is a real-life study showing the relationship of previous MI to a subsequent MI. So for those who had a previous MI, the incidence refers to recurrent MI, right? And for those who didn't have a previous MI, is the incidence of the first MI. Look at that. Isn't that strange? It looks like previous MI is more strongly related to a subsequent MI in people without diabetes. It really doesn't make any sense. This is, negative multiplicative interaction. Now let's look at the difference, the absolute difference. Now, before that, there's a possible erroneous inference. If resources are limited, it's more effective to target individuals without diabetes to prevent recurrent acute infarctions. And I've seen 2 or 3 papers in which people made this mistake. If you look at the absolute difference, then you see what you expect, even from a biological viewpoint, is that the effect is stronger in people with diabetes. So this is a positive additive interaction. And the thing is that when the baseline is high, ratios tend to decrease. So this is something that I've seen in many student presentations. They really don't understand, but that's what happens. Okay, so you have to be careful when the incidence is fairly high that you don't make this inferential mistake. Okay. All right, let's talk about decision analysis. This is another thing that I think is useful. And I think it is, the definition is here, is a tool in translational epidemiology, uses a quantitative approach to evaluate the effectiveness of one or more interventions, programs, or services. It's, the decision tree is helpful when you do decision analysis. And the decision tree has 2 nodes. One is the decision node that is under the investigator's control, and the chance node that is not under the investigator controls. And you see the decision tree allows differentiating efficacy from effectiveness. So let's take a look. Okay, say you have 2 programs. It could be anything. It could be vaccination, or it could be vaccine A and vaccine B. It could be vaccine and placebo, whatever you want. This is the decision node. I decide. And usually I should decide by random allocation, right? But compliance is very different. In program A is much higher than in program B. Okay, so now the mortality for each one of those tracks, the joint mortality is, 0.7 times 0.10, and you do that for all the tracks, all the routes, and you see that efficacy for compliers, mortality is lower in B than in A. So B is more efficacious. But because the total mortality is influenced by compliance, what happens is that the effectiveness is better for A than for B. Why? Because many more people comply. Now, I only have two nodes. Usually the decision tree has more than two nodes. Now you could do a sensitivity analysis if you want to, right? It is my definition, approach to examine changes in the output of a given model resulting from varying certain models, parameters, or assumptions over a reasonable range. So what will happen if compliance in program B increased to 50%? Now you want that to be a possible, it would be probable, to be, reasonable. Otherwise you wouldn't use 50%, you may use 40 or 30. So when you do that, here you are, compliance now is 50% in program B. Then the total mortality in B goes from 36% to 26%. Well, it's still high, a little bit, it's still a little bit higher in B than in A, but it's not too much higher. So now it's a matter of cost effectiveness. So the decision will really depend on cost effectiveness. Now let's go to something else, pseudo homogeneity and pseudo heterogeneity. And this is something that I haven't seen in any textbook or in any lecture. If anyone knows any paper about that, it would be really nice to improve what I'm going to say. So now I'm going to use a more detailed evaluation of levels of evidence. And this is one of them. They all look very similar. And you can see it goes from clinical trials, from randomized trials to cohort studies to case control studies, etc. The best is 1A, which is systematic review of randomized trials of homogeneity, including meta-analysis. And the worst is expert opinion without explicit critical appraisal based on logical deduction. Okay. Now, what you see here is very interesting. For all study designs, homogeneity is the highest level of evidence. Okay, so homogeneity is important. And, health officers and people who do policymakers, they really want homogeneity, not heterogeneity of findings. So what do I call pseudo homogeneity? Well, publication bias. Results from allowing factors other than the quality of the manuscript to influence the likelihood of acceptance for publication. And it's not a random phenomenon. There are some risk factors for publication bias. Increased odds of publication findings are significant, statistically significant. I should use the term statistically significant. Decreased odds of publication for completed clinical trials results vis-a-vis observational results. This implies that when the clinical trials are not to the author's taste, preference, they probably don't publish. Industry-sponsored studies more likely to report findings that are significant than publicly funded studies. English written reports more likely to report findings that are statistically significant. Now, it can be evaluated. And this is one of the things, when I see a paper on systematic reviews, the first thing I want to do is to see if there might be publication bias. So there are two strategies. One is to use a Baggs-Funnell plot in which you plot precision against the measure of association. And the other one is test of symmetry. So in other words, when you do a meta-analysis, you know that that's what you have to do. And people have talked about how to prevent publication bias. Publication of study designs descriptions. The AJE, the American Journal of Epidemiology, has a section on study design. So we try to encourage people to, as soon as the study is funded, to publish study design. At least people know that the study is there. And if, in 2, 3, 4, 5 years, there are no results, they can go after the authors. And registries, like Cochrane system and many other registries. That's an excellent way to avoid publication bias. Now, more interesting, pseudo heterogeneity. That is really interesting. When you see homogeneity, if you can be sure there's no publication bias, that's really in favor of the existence of effectiveness or an association. But when the results are not in the same direction, in other words, different studies show results in different directions, or in the same directions but vary with a lot of variation in the measure of association. That's heterogeneity. And people immediately say, well, if there is significant heterogeneity, incidentally, there are tests of homogeneity. You can test to see if the homogeneity is significant or not. So people are inclined to say, well, there's no association. But that's not true. There are lots of causes of heterogeneity that do not negate the possibility that the association is there. And there are some that are obvious. For example, differences in study design, procedures, analytical strategies, and quality of the study. That's an obvious one. The other one is differences in effectiveness. So external validity of effectiveness depends on the population characteristics. And we just saw that with the decision analysis. Remember, efficacy is better in A, but effectiveness, efficacy is less in A, but effectiveness is more in A. And effectiveness in this hypothetical example is a function of compliance. So effectiveness will vary according to the proportion of participants or that receive the intervention, whether or not they comply. So this is something else. So efficacy is more generalizable than effectiveness. Now, this is interesting. Difference in the phase of the natural history when the study is done. A few years ago, Arminian and Lilienfeld, they showed something really interesting. For non-infectious disease, we know that the infectious disease, the epidemic curve, the point epidemic curve of infectious diseases has a log normal distribution. Okay, this is the log normal distribution. But they found out that that's true also for non-transmissible diseases. And they showed two examples, bladder tumors in die-staff workers and leukemia after the atom bomb explosion. So, of course, before the minimum incubation period goes by, which in non-infectious disease is called the latency period, all those cases are not related to the exposure, right? So, studies do not show an association. Well, when the epidemic curve starts to go up, the studies will show an association. And it's really interesting. There's a good example, the introduction of hormonal replacement therapy. In the first 3 years, the increase in risk of breast cancer was not apparent. So after 3 years, it became apparent. Of course, not perfect, but that's the implication. And I have to say that Luke Culler, who was my advisor in my MPH back in the 19th century, Luke Culler, when the estrogen therapy was implemented decades ago, I was talking to him at the door of the School of Public Health, and he told me people are not allowing the incubation period to go by. So he predicted that after a number of years, there will be an association, epidemiology will be able to show an association. So this is one thing. There's another example which is very interesting. Observational studies have shown estrogen, premenopause, postmenopausal hormonal therapy, to suggest protection. So the relative risk is less than 1. But the Women's Health Initiative, which was a randomized trial, showed the opposite, that the relative risk was greater than 1. Very interesting. So there are possible explanations. One is residual confounding in observational study. That's most obvious, right? Because people say the randomized trial is the gold standard. The other is observational studies in the Women's Health Initiative clinical trial were done in different phases of the natural history of atherosclerosis. So let me show you. The observational studies were done about 5 years after the menopause onset, when there's little atherosclerosis. There's some intermedial thickness. Okay, so the favorable lipid and endothelial effects of estrogen predominate. Now, the randomized clinical trials, both the primary and secondary prevention, they were done about 15 years after the onset of menopause. So the prothrombotic, when there's a lot of atherosclerosis, underlying atherosclerosis, so prothrombotic and pro-inflammatory effects of estrogen predominate. So there's an adverse influence. We don't know if this is sure. This is a hypothesis, but it's a logical hypothesis based on the biology of atherosclerosis. Okay. All right. This is another reason why different study results can be heterogeneous. Differences in the prevalence of effect modifiers. Okay, so this is a very interesting, another example of negative multiplicative interaction, positive additive interaction. You know, if you stop here with the rate ratio, this is lung cancer death rates in relationship to smoking and asbestos exposure. And smoking is the potential effect modifier, and asbestos exposure is the main risk factor of interest. And you can see the rate ratio is greater for asbestos, is greater for people who never smoked. It sort of doesn't make any sense at all biologically, whereas in the current is much less. But when you look at the absolute difference, it goes in the right direction. The excess, the absolute excess is much, much greater for smokers than for non-smokers. You know, I would like to be radical and say, you know, if your study has public health potential, preventive potential, forget about rate ratios and relative risk and hazard ratios. You really want the absolute differences, okay? But the point I wanted to make is in terms of the prevalence of the effect modifier. Let me show you. Study A, okay, includes mostly non-smokers. So the absolute difference is going to be close to 31 per 100,000, right? Whereas study B, most people smoke, the absolute difference is going to be close to 555 per 100,000. So I think that's important in prevalence of effect modifiers, okay, may cause heterogeneity across studies. And finally, differences in the variability of the exposure and the outcome. You can see that this is the kind of stuff that should be taught in MP1, I think. All right, this is very important. To detect an association in observational studies, both exposure and outcome have to vary, right? So my example is relationship of salt intake to high blood pressure. If most people eat a lot of salt in that population, you know, a few years ago, the average consumption of salt in the United States was enormous, about 7 grams per day. Now it's better, now it's much better, much lower. Well, if there's not much variation, there will be a weak correlation between salt intake and systolic blood pressure. But if there's variation, there will be a strong correlation. So you have study A and study B, very different, showing heterogeneity. It's not that there's no association, it's just a matter of the variability of the exposure, okay? And I'm going to recommend to all students, as a matter of fact, that whenever they do an observational study, that they look at this coefficient of variability. It's a very easy way to show whether or not there's sufficient variability for an association to be apparent, okay? All right, so let me show you that not always the ecological data result from ecological policy. I had a series of slides. If you bear with me for a second, I deleted those because I eliminated those because I thought I wouldn't have time, but I think we're okay because I'm almost done. So just bear with me for a second. I want to show you these slides if I have not. Okay. Do you see this? Strong correlation between per capita consumption of margarine and divorce rate in Maine. Perfect. Correlation coefficient is almost perfect. Now, if you eat a lot of mozzarella cheese, there will be fewer civil engineering doctorates awarded, also with a very strong correlation coefficient. And this you never guess. This is a reasonably high correlation coefficient. This is the coefficient, this is the correlation between number of storks and the size of human population. So ecological fallacy is, of course, very possible in studies of ecological studies. But let's go back to what I was saying before. Okay, so, okay. So say this is a hypothetical data on individuals from a worldwide population, okay? You can see there's a strong linear association between per capita daily intake of salt and systolic blood pressure. Now you look at the populations without, excuse me, the population within the world. I mean, each little color means a different population. So in country A, there's no relationship, right? No association. In country F, there's no association. Now, if you look at the averages for each country, then you see a strong linear association. This is an example that ecological correlation are not always wrong, and individual-based studies are always right. And this is a good example. Again, if you're doing an observational study, I think it's very important to look at the variability of both the exposure and the outcome. All right, so I want to finalize by just showing you. So this is a positive, of course, linear association. And this is the intersalt study. It's not perfect, but each little dot is a different population, a different center with a different population group. And you can see there's a linear relationship. In fact, this happens too. This kind of phenomenon also happen, also happen in intake of saturated fat. You know, the relationship between saturated fat and coronary heart disease was not terribly apparent in the first Framingham study reports. And that's because people are eating a lot of saturated fat above the threshold to cause atherosclerosis. So you have to be attentive to the variability of the exposure and the outcome, of course. All right, so homogeneity is not necessarily evidence in favor of causality effectiveness. And heterogeneity is not necessarily evidence against causality effectiveness, okay? There's determinant of homogeneity, heterogeneity should be better understood before using these concepts in a radical way in support of effectiveness or lack thereof, respectively. Okay, so translational versus theological epidemiology, some key differences. Translational focus on application, right? In etiological focus on etiology and mechanisms. Translational epidemiology favors measures of association based on absolute difference, and thus it focuses on additive interaction. Whereas etiological favors relative measures of association, and thus it focuses on multiplicative interaction. Public health confounding is useful to identify high-risk groups. Etiological confounding is a bias akin to selection bias. Translational favors effectiveness, and etiological favors efficacy. And just to finish, my mentor, Dr. Comstock, one of the three epidemiologists, best epidemiologists that I ever met, he says, if it isn't ultimately aimed at policy, it's not worth doing. Sort of a radical statement, but he reminds us that epidemiology is a tool of public health. So actually, he also told me something that I want to pass to you, which is quite funny. It is not related to this presentation. You know, when I was an assistant professor helping with Epi 2, Epidemiology 2, George Comstock was the main instructor. And one day he decided to ask me, what is the best way to analyze data? And I started to mumble something about regression and analysis of covariance and so on. He said to me, no. The best way to analyze data is to look at the data and think about what you see. So that's it. Thank you very much. Appreciate it.
All right, thank you so much. Wonderful
Well,
talk.
Wonderful.
wanted to make a comment or ask a question?
Yeah, I think we have time for any questions. Let's open it up to the group. I suppose you can either raise your hand or type in the chat, whichever is easier.
I see David Dowdy has a question, and then we can go to Joe Koresh after.
Great, thanks. And Moyses, excellent talk as always. I'm always excited to see more of an emphasis on translation and policy. I'm curious to hear from you if we were to have maybe 2 or 3 priorities for kind of education and training of the next generation of epidemiologists, trying to make our discipline more translational. Like, what would you put at the very top of things that we need to be teaching our students as far as making epidemiology more translational, more worth doing?
Wow, that's a very sweeping question. I haven't thought about that. I think some of those concepts can be expanded a lot. And, there's a little bit of a black box philosophy amongst epidemiologists. So if you go to books on modern epidemiology and you want to look at the interaction, people, you have to, it's all abstract, all, derivational formulas and numbers and so on and so forth. And I try to show that it's a very simple kind of phenomenon. And I think it's useful to define high-risk groups. I'm not sure exactly. I think they ought to be more exposed to the application of epidemiological methods in the relationship of each method with some form of application. But I'm not sure that I can answer your question. It's too sweeping, and I haven't thought about it. Sometimes when people ask me questions, I feel like placing an ad on my door, my office door, saying, "Closed because of lack of knowledge." Sorry, David. What about you? What do you think? Raise David.
You might have had to.
Yeah, no.
Might have stepped away.
I'm happy to take the challenge. I mean, I would agree with you that in general, probably what we need to do is more practical education, giving students more exposure to both successes and failures in translation.
Yeah, I think interaction with health officers.
Yeah.
Interaction with, for example, there are certain things that are not actually now being taught by Carlos. Why do you need surveillance, for example? What is the purpose of surveillance? And how do you translate surveillance findings into action? So I think a more transdisciplinary kind of approach in which the epidemiology students could relate to health department people, people who do policy in agencies, the United States Task Force. I think we have to learn what those people do and how epidemiology serves those actions.
Yeah, no, I agree. I'll let others chime in, but I do think it'd be nice to think about how to develop a case-based epidemiologic curriculum that focuses on some of these issues. Yeah.
I also wanted to be sure that the students have an opportunity to ask any questions. Are there any students who have any ideas or thoughts or questions? Don't be shy.
I think Joe wanted to ask a question.
Okay.
Well, there's those of us old students, even though I prefer the younger students. I've been known to make the cutoff of under and over 40, so we should get a question by the under 40 crowd. Dowdy may make it. I don't know. So Moyses, related to that, I've always underestimated when I was younger the value of networking. And I'm curious if you could give us any examples of when people in power for translation listened to what you had to say, right? Because I suspect things work much better when people want to listen than when we tell them things they don't want to hear. Are there any common factors or just examples of when it just happened that it was the right time and place?
Yeah, I think that's, again, is a interesting question. I'm not sure I know the answer. My experience actually is the opposite. Is coming up with a recommendation that people in power did not want to follow. And I want to give, an example. Again, a few years ago, Brazil had a very excellent Minister of Health, and he wanted to know whether they should implement mammography for secondary prevention of breast cancer, screening of breast cancer. And, I found out that one of the problems in Brazil is that women were diagnosed with relatively advanced breast cancer. And then mammography was expensive, and the maintenance of the mammograms was not easy, and so on. So I suggested, based on a Canadian trial, that they do physical examination of the breast. It could be done by nurses, as a matter of fact. Nurses can train like they did in Canada. In Canada, they did a randomized trial. And I suggested the Minister of Health adopt that as a policy, because Brazil has a national health service, a socialized medicine. So it would be relatively easy to train nurses in the clinics, in the public clinics, to do a physical examination of the breast. But the radiology lobby was very strong. Yeah. And they decided to ignore my recommendation and went on, and use mammography. But it was a disaster because of the cost. And, if there was a problem with, the machine breaking, there was no one to repair the machines, and so on and so forth. So this is on the other hand, when I suggested a plan based on the natural history, they accepted it. So now they have clear-cut primary prevention, primordial prevention, primary prevention, and screening, and also care of terminal patients with cancer. So that was accepted, and they changed and that's one of the reasons I got that award.
Yeah, but it seemed like part of the root cause was somehow the Minister of Health was talking to you. Why did that happen?
You talk about the radiology group?
No, the Minister of Health of Brazil.
Ask your question again.
The Minister of Health of Brazil was talking to you. That seemed like step one.
Oh, yes. He was talking.
Why?
Because he was a personal friend. That's why. So I was a personal friend, and he suggested I be a consultant to the health minister. But there was one thing that I think was an advance, because I suggested a unit of evaluation of health technology. And, in the definition includes not just, x-rays and all kinds of contraptions, but also includes programs. So the definition of technology is very broad. And he allowed me to set up a unit of health evaluation, technology, health evaluation. So theoretically, the action for the federal institutes, they have a National Institute of Cancer, National Institute of Cardiology. Their actions are based on systematic reviews by the unit of health technology evaluation. So that was accepted. But things have changed radically, because now we have a different Minister of Health, and the present Minister of Health is just horrible, doesn't know anything. Do you see any similarities with? Anyhow, sorry, I sort of rambled a little bit, so I didn't answer your questions too.
No, I think you answered my question exactly. I think somehow we need to learn rigorously, and then we need to be in communication with people in power. And then, as you say, they have to be interested in knowledge and data. It has to have all of the above.
Yeah.
Hi, Dr. Szklo. Can I ask a quick question? Actually, can I ask two questions?
You
So one question is around qualitative data. What role do you think that qualitative data have in sort of translational epidemiology? The sort of emphasis on the talk was on, relative risk ratios and things, but I think qualitative data can have a powerful impact when you're sort of trying to reach people, and that part of it is often sort of understated. The second question is around social media. What role do you think social media can have in relationship to translational epidemiology? Thank you.
It's really
Great
interesting.
questions.
Yeah, because when I was, it's really interesting because I identify myself with cardiovascular epidemiology, but basically I am like a dying species of general epidemiology. So because of my role as the editor-in-chief of the AJE, I also had to learn a lot about cancer and other chronic diseases, non-transmissible. So when I suggested to the minister to create a unit of health technology evaluation, interesting your question, I also suggested the creation of a department of population research. And that department had 3 units: qualitative research, epidemiology, and health technology evaluation. And we found qualitative research very useful in terms of creating focus groups to discuss things like compliance, acceptance, cultural issues in terms of accepting a given program, and so on. So I don't know what happened to those, but for a while we were doing that. So I think qualitative research, and incidentally, I don't know much about qualitative research. People whom I knew who were doing qualitative research convinced me that the Department of Population Research ought to have a unit of qualitative research as well. And I found out it's useful. It's also useful to develop some hypotheses that could be tested, in epidemiological studies, but that's a different story. Now, social media, social media theoretically is incredibly important, right? In terms of application of knowledge. And we are having a national experiment now with social media, but I don't have any good answer.
Might be a good topic for a future seminar. Well, I just want to be mindful of time because it's just about 5 o'clock. Any one last question, perhaps? If anybody needs to drop off, that's okay too. Great. Okay. Well, thank you everyone for coming to this first seminar series. Keep an eye out for the next ones coming up in the next few months. Dr. Szklo, thank you so much for agreeing to give this inaugural seminar. And just as a reminder for the students, this is being recorded, so we will make the recording available somehow, but stay tuned for that. So with that, hope everybody has a great evening.
Bye.
Thank you very much.
Thank you very much, Dr. Szklo.
My pleasure.